Inspired by the ideals of Mahatma Gandhi, a doctor couple in one of the remotest areas of Maharashtra affected by Maoism has been working tirelessly for rural and tribal health for over 4 decades now. Several national and international recognitions have been bestowed upon Dr. Rani Bang and Dr. Abhay Bang in all these years. I'm in Gadchiroli, in the sprawling campus of Search or Society for Education, Action and Research in Community Health, founded by the Bang couple sitting right across them. Hello and welcome to Pulse Maharashtra with me, Vinaya Deshpande Pandit. I'm the Maharashtra Chief of Bureau of the Hindu and your host for the show. And today I have with me the pioneers of community-led health initiatives, septuagenarians, Dr. Rani and Dr. Abhay Bang. Thank you so much for your precious time for the Hindu. I want to begin by asking you, it's been 2 decades since the ASHAs started working in India. It was primarily thanks to your initiative in community-led public health service. How do you look at ASHA services now and how do you review this entire period critically? What needs to be done now?
So ASHA is a name for community health worker, female community health worker in village. Idea is quite old. Even Mahatma Gandhi and Rabindranath Tagore, they started something like trained community health worker around their ASHA. Then people like Dr. Arole in Jamkhed, they also trained community health worker. What we did in Gadchiroli, that we identified a woman in each village and trained her to manage very serious condition which used to kill children in India. These were pneumonia in children and newborn care. And not only we were able to drastically reduce child mortality in this part of Gadchiroli, but through field trials, controlled field trials, we could show that there is serious scientific evidence which was published by the Lancet and that gave its international credibility. ASHA program was conceived by then UPA government around 2006.
2005 years.
One reason was that the access to healthcare was very poor. In the 90s, government fell for a World Bank pressure or IMF pressure that people should pay for their services and receive private care. Even government services started charging fees. So access to healthcare remarkably reduced. UP government really made a qualitative change and National Rural Health Mission and ASHA, these 2 ideas were floated. ASHA's ideas, as I said, there were several barefoot doctors in China. So there were several inspirations, but probably Gadchiroli program showed them clear-cut evidence that it can be done and it effectively reduces child mortality. So I think it was a very major step to accept by the government that a non-professional, like a semi-literate village woman, that she can be entrusted with the responsibilities of healthcare. When we used to do lobbying with the government that there is a need in village, but you don't have any worker in the 5 lakh villages of India, so there is a need for a community health worker. The resistance was both from bureaucrats and technocrats. What would a semi-literate woman would do? You always need doctors. They used to compare with the international standards. But Indian villages did not need international standards. They need something which was immediately accessible 24 hours. So finally, when government was convinced and they introduced ASHA program, initial some years really went into what we should be doing. Gadchiroli model and the Mitanin model in Chhattisgarh. These 2 models helped Government of India to design ASHA program. We trained the trainers, national trainers who trained district trainers who trained about 10 lakh ASHAs. So currently there are 1 million ASHAs in India and last year they provided home-based newborn care in their villages to 15 million rural neonates. So this period saw the most remarkable drop in child mortality, which had never been seen, so rapid reduction. So ASHAs have proven their effectiveness not only in reducing child mortality using home-based newborn care, but in several other programs. Now actually, health department, I am using it in a complementary sense that health department is now addicted to ASHA.
Yes.
They cannot
They
do
become the
anything,
backbone.
they cannot do anything in village without ASHA. Whether it is COVID control or malaria control or TB control or hypertension, diabetes detection, everything, ASHA is the frontline person. So it's a remarkable tribute to the capacity of a rural woman. That if you give her training, opportunity, and then medicine, supervision, financial remuneration, she can really do miracle. That's why the logo that we created for home-based newborn care is that in a dark hut, a woman is alone, but on her raised, empowered hands, she can take care of the health of her child as well as of the village. So ASHAs have really done remarkable contribution to India's healthcare. And today, if health department has some presence, though inadequate, but some presence in 6 lakh villages, thanks to ASHAs and ANM.
But Dr. Rani Bang, we have seen that for the last few years, the ASHAs have consistently been hitting the streets. They have been raising several demands that they say have not been met with. What do you think should be the way in which ASHAs should be valued and their contributions should be recognized? Because it's not just the health services that ASHA are, offering to people, but beyond health as well, there are several other jobs that have been put on their backs. In Maharashtra, for example, you see for Rani Bang and Dr, the Anganwadi Sevikas, the ASHA workers have also been the frontline people to have been a part of the enrollment. How do you see that they consistently feel that they are not valued?
I feel that ASHAs are overburdened and everybody talks about ASHA and we have forgotten now ICDS workers, village health workers. They should be given proper importance. That is one thing. And ASHA should not be considered as panacea for all the problems. She has to do limited responsibility which she can do properly. So, like family planning program in many years, in Sanjay Gandhi's region. So, family planning program was supposed to be panacea for all the problems. Same thing is happening with ASHAs. And I think that they reduce the quality of the care.
Two more things have been done.
Quantity. Everything is based on quantity. This work, that work, that work, that work. I think that when importance is given to only quantity, quality definitely suffers. So government has to decide what are our really main priorities and work on that. And I think here, the people who are working in the field, they can play a major role and they should play a major role.
So ASHAs need to be given more role but defined. What currently is being done that you identify the illness and bring to the door of PSC. But there is no doctor at that PSC. There is no community health officer often absent. And so instead of making her merely a recruitment agent of patients for healthcare system, she should be empowered to manage cases. That's one. That will give her more credibility. Instead of she saying to everything, you have some illness, now go to the PSC for the illness. Secondly, that her training and supervision needs to be strengthened. Third is she should regularly get her financial incentive. Her payment is largely linked with amount of work output that she produces. Now, once you have made this kind of financial arrangement, then you should be honest to it. You should pay her adequately for whatever work she has done. System is not very efficient in that. And finally, this is true that ASHAs are doing not only several work, but in our area we find that people often insist that ASHA should become a sarpanch. Our community health workers, Sri Arogya Doot, that are initially trained, many of them villages want her to become sarpanch of the village. So actually, there is so much needed at the village level, health work, that you need 2 or 3 community health workers in each village. So along with ASHA, in addition to her, there is a need for one more male and one more female community health worker. For 1,000 population, healthcare needs, especially in the era of non-communicable disease. Every village now has got 200 hypertensive and about 40 diabetics. And then old people who need much more care. What a single ASHA can do. So we need to expand the quantum of community health workers at the village level. You need at least 2 or 3 community health workers. I have even designed a name, I coined a name for male community health worker, Ashok. Ashok, one who reduces pain and suffering. So Asha and Ashok, that is the minimum that each Indian village needs and deserves.
When you say that, what is the quantum you're talking about as compared to the millions of ASHA workers that we have right now? How many Ashoks should India have?
India has got nearly 6 lakh villages. And if you include tribal small villages, padas also, that might go as much as 1 million. So the same number of male workers, I would say same number of additional workers, whether male or female would depend on the job description. Probably female workers would be more stable in the villages. Males are always looking for job around. So female would be more stable. But one limitation of ASHA is that they may not be so much reaching out to the male clients. For example, vasectomy, use of Nirod. So they may not be so effective. So a pair of male and female worker probably will create access to all the population. But additional worker could be male or could be female.
But doctors, we're also talking at a time when we see that the public expenditure on health is questionable. Both of you started your work with the aim of Arogya Swarajya, highly inspired by Mahatma Gandhi's ideas. This is what you wanted, to happen in India, which is why you chose Gadchiroli, which is one of the most underserved areas, which is, which had so many problems, infant mortality rate too. But at a time when, we are seeing that more and more focus of health services is towards privatization, how do you see India achieving the goal of Arogya Swaraj?
By Arogya Swaraj, we mean that as much as possible, people should be able to take care of their own health by determining how do they live. My health depends on my diet, my exercise, my mental peace, my use of substances, tobacco, alcohol. If I don't change these, then only thing I am going to do is to get a cancer or get a stroke or a heart attack and then end up at the door of medical care system. And so Arogya Swarajya means I am empowered to take care of my health. Individually, family-wise or community-wise. And most of the care for illnesses should be possible within the community. Which villager wants to go to some city and wait outside a big hospital? So they need everything in their own village. We should be able to provide that. So power in the hands of people, in individual and family, to prevent illness, to live in such a way that illnesses won't occur. Now tobacco and alcohol have become so common in India. Fast foods have become very common. Excess use of sugar and salt have become very common. And these produce all non-communicable diseases. Once you develop non-communicable disease like heart attack, stroke, diabetes, hypertension, cancer, then it's lifelong disease. It needs higher level of
Swast.
It's not swasth, it makes you aswastha, dependent on somebody else. And so, empowering people to live a healthy lifestyle, to manage their own health in their own hands, and especially modern technology makes it eminently feasible. Now with the self-monitoring devices, you can monitor your pulse rate, your BP, your sugar, your ECG can be taken and tele-connection so that if your ECG is wrong, immediately you will get warning signal. The modern apps and teleconnectivity have made it eminently possible that people should be able to manage their own health. And more we do it, more we will reduce their dependence on the medical care system. Still, for 10-20% illnesses, advanced medical care system will be required. Their government cannot shun its responsibility. Government has to provide for that. Countries in the Europe, on an average, spend about 10% of their GDP on healthcare. And their GDP is very high.
Yes.
So 10%, for example, US spends 17% GDP on healthcare, which comes to about 10 lakh rupees per capita per year. We spend something like 6,000 rupees per capita per year. And government spends, state and central together, around 1% of GDP on healthcare. So huge amount of resources have to flow in. Instead of that crowds to get into medical colleges, actually public health services which health promotion, prevention and primary health care. That's where we need our emphasis. And the current government allocation to healthcare must increase 3 to 4 times. That is necessary.
But Dr. Rani Bang,
I personally feel like this is very important, what Abhay has said, and we are doing the same thing. But nowadays, villages are growing. There is no concept now that village is a unit. There is a rapid urbanization, and people are very much tend to go to district place or medical colleges. I think they also should be strengthened because the paucity of doctors there, that is also an important aspect which we ignore. Most of the doctors nowadays, they tend to settle in big cities. There is no concept of private practice. Now, one person cannot run the clinic. So many doctors have to come together. That's how corporate sector is created. So, in urban areas, we should be able to motivate the doctors there. Not only just clinical care, but also the preventive care. That is very important. Nowadays, what is happening? They are supposed to treat all the chronic diseases. But the primary health care in urban areas, that is totally neglected. So there also we should be able to emphasize. And also women's.
that is my next question to you, that how do you see the fact that public health system has its own problems? How does it compound women's problems? Is it more difficult for women there?
Yes, definitely. I just give you one example. Previously, we used to have this dai concept who used to deliver in the villages. Nowadays, dai concept is totally gone, and that is because of the health program of the government. Institutional delivery. That every woman should go to hospital and she should deliver there. The women who are getting the services at home, we don't need very elaborate services at home or in the community. But now what is happening? The doctors at the community level, they're at sub-center, the nurse is there. In rural hospital, another doctor is there. District hospital, another doctor is there. And because of this concept that not a single death should occur, maternal death or infant death. And so nobody wants to take risk. So there is a hierarchy there is there in medical community. So if patient comes to PSC, even for delivery, she is sent to sub-center. District hospital. And there is tremendous load in this, which of course affects the quality of the care in district hospital. So, and secondly, what has happened is because of these institutional deliveries, the number of cesarean sections has rapidly gone. And I talk to many doctors. They say that who is going to awake in the whole night and look after that patient? Most of the deliveries they take place in the night. So we can do cesarean section. We can get money, and at that time we can finish our job everywhere. I have seen these doctors, women doctors, saying that, like in other sector, government sector, they have a job from 10 to 5 or 11 to 5. So same way, all the doctors should have this type of duty.
That's what doctors say.
That is going to affect, that is already affected.
So on one
you were-
hand, there
you were
is a
asking-
large scale of commercialization of medical
That is-
services.
that is
On
there.
the other hand, there seem, the problem with the public health system as well. And, how do you find a sustainable solution to this?
Look, you were earlier asking about the human resource in healthcare system. In most of the developed countries, 2% of population is involved in providing healthcare. Now imagine if we apply same proportion, their salaries in the US will be different than in India, but 2% of population is required to provide healthcare. So an average village with 1,000 population should have 20 persons. Assume that half of them would be in urban areas, in hospitals, etc. So India should have altogether nearly 30 million people involved in healthcare. From ASHA and Ashok to ANMs to lab technicians, etc. to tertiary care surgeons. But India should have 30 million people involved in healthcare, and India's health budget should be at least 3 times more, and then you see the picture can change.
But then do you see that, the villages, the tribal areas, the hamlets particularly, the marginalized of the most marginalized are left in the lurch because of this gaping hole in the public health system and the large scale commercialization? And how does one address that?
But that's what Arogya Swaraj idea can provide for. Arogya Swaraj means that apart from government system, we should be there, and probably there is going to be a private system also. You can't completely put it aside. But then 70-80% of health preservation and healthcare role is shifted to the village level. And then the tribal villager doesn't have to go to cities for everything. Most of the health prevention, like the vaccination, we provide in the village. Iron folic acid tablets we provide in the village. Similarly, for most of the healthcare issues can be provided in the village, and 20%, 30% maybe higher centers are necessary. Tribal villages will become more accessible if we select individuals from the village itself and train her or him to provide healthcare. If you select doctors from Mumbai and Delhi and compulsorily ask them to go and live in tribal village, they are not going to. We have had enough 70 years experience, failed experience, that you can't operate that model. So better idea would be select a potential man or woman, young man or woman from the village and turn her or him into barefoot doctor. So in tribal villages, if they can do their farming, if they can do their forestry, why not healthcare? Healthcare can be simplified and made accessible to tribal villages also. So 6 lakh Indian villages need a healthcare, small but healthcare autonomous system in each village. That is Arogya Swaraj.
On one hand, this is very important, but nowadays these villagers, they have also another feeling. They want to go to big hospitals. They want sonography in every case. Nowadays, they are talking about CT scan in every case, MRI in every case. They come with different doctors' prescription. At the same time, they bring sonographies of different doctors. So that is also another thing going on. And with people in village, they have also different expectations that what was there before. So we have to take it in consideration.
But that can be made available with Rani. Look, now on our mobile medical unit, we have put mobile X-ray and we have put mobile lab. So in every tribal villages, our mobile medical unit takes X-ray, laboratory and medical care. Now, not so far CT scan and sonography, but with emerging technologies, more and more simplification would happen. The machines are becoming smaller and smaller. And with teleconnectivity and with teleconsultation, the expert might sit in cities, but he or she can offer intellectual services to even tribal village. So I see a very much possibility that with AI, where the program, if X-ray is taken in the village by a technician, AI would give diagnosis. Or a teleconsultation, doctor sitting somewhere might give diagnosis. And so the advanced medical care facilities can be made available right in a tribal village or in any of the 6 lakh villages of India. Government needs to have that vision. Vision of Arogya Swaraj, not merely medical insurance through corporate hospitals.
Which means you're saying that adequate medical infrastructure funded by the government at rural areas, which can then be combined with AI and telemedicine services. Am I right?
In addition to empowerment of the human beings in the village. So AI teleconsultation would be additional. The real thrust would be give knowledge and lifestyle, healthy lifestyle to the people of villages and give community health workers who would assist them at the village level.
I think that we should also be very clear now because of the expectations of the people and they want good services. We always talk about telemedicine. That is very, very important. But who is there on the other end? Who is the specialist who is giving the care, advice? I have seen some doctors. They say we don't have time. That is a problem. We usually say that should be telemedicine and all that. But who is there at the other end? And is there, if at all there is the advice is accepted, how to bring the medicines, the investigations. Not every investigation is available at rural level. So we have to think in total perspective, not just community, not just corporate hospital, but there should be some middle solution. And we have to proceed in this direction.
Dr. Rani Bang, I want to ask you something with respect to specifically women's health. Now, your work has been pioneering with respect to women's reproductive health. We've seen also how there was a global shift of focus from birth control to women's reproductive health influenced because of your work. But even today, challenges remain. What do you think are the biggest challenges in India when it comes to reproductive health of women? And how challenging do you think is, this very loose over-the-counter sale of medicines, especially when it comes to women's health, reproductive health?
One is cancer, that is emerging. That's a big problem. Both breast cancer and cervical cancer. Nowadays, MTP law was there in India since 1972. And number of illegal abortions or criminal abortions were nearly 6 times more than the legal abortions. That time we said that there are no services in rural area. So we tried to provide services in rural area. But what is happening is the technology. I am not opposed to technology. Technology is important, but now after pill and emergency contraceptive pill, that is creating a bad thing because most of the women, married women and most of the unmarried girls, and now this premarital sex, previously also it was there. In our study, we saw that 48% of girls have premarital sex. But any abortion which is done without the doctor's prescription, so that is called at a certified center. That is called illegal abortion. Previously, there was the other type of illegal abortion. Nowadays, we are having other type of illegal abortion where women take the medicines on their own. They don't know what is the uh, regime, how to take the medicine, and they don't know what are the side effects of the medicine. And this whole thing needs lot of health education, not only in villages, but in urban areas. Because most of the educated women, they don't know anything. They think that it's very easy. Do anything, and the technology is there to help.
But what are the harmful effects on women's reproductive health when such over-the-counter prescriptions, over-the-counter medicines are taken without prescriptions?
One thing is menstrual problems, irregular menstrual problems and heavy menstrual problems. At the same time, some medicines, if they take hormones, it may ultimately lead to infertility because the ovulation is suppressed. Adolescent, it affects adolescent sexual and physical health. Because of this, many girls and boys, they indulge in irresponsible sex and infection is there, but at the same time, premarital pregnancy nowadays indulge. That is also there. And in rural area, most of the females, they resort to this criminal abortion. So irregular menstrual cycle, and women in India are very much concerned about menstrual cycle, menstrual flow. And if there is a heavy menses, they think it is normal. If there is less menstrual flow, they think that is the most dangerous thing. So they are very much worried when they take all these medicines. They are very much worried about the infertility problem or in general their total health, because they think that if the menstrual flow is less, that is going to kill that woman, because that menstrual blood collects inside the uterus, and it's very important. It impinges on the heart, and she might die.
That's what they believe.
That's what.
Also, retained products, if they use
Yeah.
medicine for abortion.
About. Because of this self-induced abortion, many times women and girls, they come with incomplete abortion. And there are products retained inside the uterus, which is very, very serious, because that may cause infection. In long run, that may cause infertility. And secondly, cancer danger is also there. So all these things we have to take into consideration. Sexual education of boys and girls, I think that is one of the missing links, and it should be added. When we were talking about reproductive health, we said that reproductive health should include all these aspects: safe and effective family planning services. Because previously there was all the emphasis only on the targets. Now also, the government had changed the policy on paper that it won't be target-driven family planning. Family planning would be for the better health of women and children, but it is not being.
Even both of you, while speaking now, have talked about the importance of sex education, particularly among adolescents, among young adults. We see that the conversations around sex education have been reducing in India. What is the significance of sex education? At what age should it be imparted, and how should it be done?
It should start from the age 12, because nowadays women are, because of the physical growth, the menarche is happening at the early age. And they are exposed to sexual relationship at such an early age. Then either they take contraceptives, or they go for illegal abortion. When we say illegal abortion, it's not the abortion done by the quacks or other doctors, medical doctors. Even MBBS doctor without any license, if he does abortion, that is considered as illegal abortion. So, adolescent sexual health education should include all these things.
You have been giving sex education here at Search for tribal youth specifically. How has your experience been? Has it changed any behaviors when it comes to sexual behavior among tribals when you see that long-term sex education is imparted to adolescents?
Look, society is changing because of so many forces. And as all of us know, first the TV, then mobile phone, YouTube, and pornography. Everything is impinging and reaching to tribal villages. So it is difficult to say what is changing their behaviors. Their knowledge has definitely increased. The sexual education for adolescents that Surge does gives them a long and remarkable information and sometimes even attitude education. Youth is changing, but it is difficult to attribute it to a single factor because all those things are happening simultaneously. And I think now media is shaping their attitude towards sexual health rather than anybody else. More than healthcare system, it is the media. What they see in films.
I'm now going to ask you to do something really difficult, that is to judge your own baby. So, 40 years ago, you started Search from a warehouse in one of the most underserved districts of India, which is Gadchiroli, which is where you're sitting right now. It was also one of the worst natural affected areas there. How do you look back at the journey? How has Search evolved and what are the challenges ahead?
So by baby you mean Search.
Yes, not your two babies who have taken over from you now.
Now we have grandchild also. So actually, when you say baby, I first think about my grandson. I think when we were studying in the US, we used to think, and when you are abroad, your own country becomes even more dear to you. So we used to dream that after returning, what will we do? We were committed to improve health of rural India. That's why we went to the US to learn public health research. So whatever dreams we had developed, I think we were fortunate that we could do much more. It was in a way a hard journey, but a beautiful journey. Very rewarding. Initially we made some blunders. And fortunately, we didn't crumble, but we learned from those mistakes. And listening to people was the most remarkable thing that we added to our methods. So, listening to people and simplifying science, taking to them, but whatever we did, we validated through scientific methods. So, though we were able to provide service locally, the research impact happened globally. So it was great to work in Gadchiroli, but to influence the health policies in Geneva, New York, Washington, and Delhi. That gave whatever work Search did locally, it gave enormous impact to it. We have called that method as research with the people. So Arogya Swaraj and research with the people, these two methods, one dream and another method, they have made whatever service or research we did here. Plus look, providing service, I have worked in urban area also when we were studying in medical colleges. It's very impersonal care. Not only patients don't feel satisfaction, but even doctors don't feel satisfaction. You have a crowd of 100 patients, you phat, like Kasai Khana. You treat patients. There is no personal relationship. Now here in Gadchiroli, in tribal villages, when we see patients, we know you come from Budega or you come from Pondavai and in your village such and such old man is there. And so you can establish personal relationship with the patients. And you can see that patient subsequently and someday or other you meet that patient in the village. So providing healthcare to tribal people is very rewarding. They are so grateful. And maybe you do contribute a little significantly to their lives. So they are very grateful. So instead of crowding and going in urban area where there are a lot of crowds of specialist doctors, you also open your shop. So what is value addition? It's so much more rewarding to come to tribal area and provide healthcare where there is nothing.
While talking to women in rural area and tribal area, I found that they have taught us more than what we have given. What are the things which I never learned in medical college? Here, talking to women, they taught me how the people perceive different types of diseases. What are their beliefs, practices? If they take medicine, why? If they don't take medicine, why? So we always take it for granted that we are the doctors, we know everything.
Can you give us a few examples when you say you learned when women interacted with you? What did they tell you that you learned from this?
Now I'm going to proceed on. In these sessions with traditional birth attendants, I used to tell them that I will teach you something and you teach me in exchange something. It should not be one-way process.